Hello, viewer. Welcome to Health Talk. My name is Betty. Thanks for joining us. I am joined by a guest. Today we are discussing a very important topic. I guess this is mostly for the interest of women, but you could watch out because you are maybe a man and you got a sister, you got a wife, you got a relative who may want to get this information. If you are watching, we are very grateful that you're going to be taking note for them. I would like to welcome my guest to introduce himself before we can take up our topic today.
Hello, my name is Dr. Moses Njoroge Ndungu. I am a consultant obstetrician and gynecologist. I practice at the Rai Family Health Group, specifically at the Specialist Hospital. And I'm happy to be here, happy to participate in the conversation we're about to have today. Yeah.
Welcome, Dr. Moses. Today we're talking about maternal care. When we talk about maternal care, we know that this is so specific to women. Yeah, but I have invited men to also just come and listen out because sometimes it's better if not all of you, but one person at least has knowledge and information to help the other. So maternal care, what is this?
Before I even go to it, yes, I agree with you. Maternal care is about women, regarding women, but we've moved away from, those days when women would walk themselves to the clinic. And we are actually advocating for more men to partner and, participate in all of this. So it's actually, it's for everyone.
It's for everyone.
It's for everyone.
Okay.
And when we talk about maternal care, this is broad because this encompasses all the care and attention that we give to women in the reproductive age, especially. And because of the focus of our conversation, I would have liked to look at it, the way from right before conception. We have maternal care that we offer women. We call that preconception care before they conceive.
Okay.
We have the care that we offer women at the time that they have, they're already pregnant.
Yes.
And we refer to that as antenatal care. There's the care that we give them when they come, they're in labor, and we want to make sure that they have a safe and normal delivery. So that is intrapartum care. And of course, we have the care that we give now the mother and the baby after delivery. So that's postpartum care. So we can look at it from those different facets, and hopefully there will be some pointers for both men and women to gain from. Yeah.
Right. I like the fact that we have moved from that age when it was a woman's responsibility to take themselves. These days, the men also have to go with the woman. Before we get to that, because I know that being a woman, I've done ANC, and so I know the importance of maybe having the man being there because you probably carry out some blood tests to ascertain what blood group he is and mine is, and whether at some point you need some, anti-D injections and those things so that my baby is well. But before we get there, you have talked about 4 segments, if I heard you correctly. And so you talked about the pre-conception. And you have mentioned women who are in the reproductive or the productive age. So talking about the pre-conception, why does a woman need this care? I thought it's just normal. If you are in the productive age, if you want a baby, you'll just get pregnant. But of course, yes, I know that there are people who struggle. Why should we come to the hospital at that time?
Okay. Again, for a very long time, preconception care has only been for the women who were struggling with one condition or the other.
Okay.
Maybe they were struggling with getting pregnant in the first place, or maybe they had other pre-existing medical conditions. But we are pushing and saying that it is important that all women who are considering getting children attend at least one session with their healthcare provider, their gynecologist, and discuss preconception care. Because there are so many things that are encompassed within that, which probably I'll go into slightly more detail, that enable you to get a normal. The whole process is aimed at reducing both maternal and neonatal morbidity during pregnancy. So there are things that we will advise you on, or a process that will be done during the preconception counseling that will help you achieve that. Get a normal pregnancy with the resultant normal, healthy newborn. So every woman would benefit from that.
Every woman.
Every woman would benefit from.
So it's not specific to women who are struggling to get pregnant.
Not really. That has been the trend, but we are now advocating the general trend, the general push by us as healthcare providers is to have every woman in the reproductive age who is now contemplating getting a child to visit their healthcare provider. And I'll tell you why. Maybe now when I'm going, I can actually go into it, because what preconception care essentially involves, there is a health promotion part.
Okay.
So we will talk about when you come to visit me and, you tell me, you and your partner are planning to have a baby in 3 months. So we'll talk about the things that you need to be prepared about. What are the nutritional requirements that you need to be to receive yourself? Like, what should you be eating? What change in lifestyles must you embrace so that you're able to conceive at a time when you are at your most healthy, if I would put it that way. So there will be nutritional counseling. There will be supplementation of your normal diet. And when you come for preconception, all the women who come, we put them on folic acid supplementation. And this, like I was saying, is for every woman. It's not just for those who have other conditions, because you see, folic acid supplementation has already been proven to reduce incidences of neurotube defects, and these are congenital problems that babies are born with, by almost 2/3. So mothers who have been put on folic acid before conception have been shown not to get those defects in their children. So any woman would be happy to remove that risk of her baby getting.
So at least there's such a great benefit
Yes, so
that I guess a lot of people are not aware of, because many times you just hear someone is struggling to conceive, and what they are basically working on is timing their ovulation. They are not into supplementing, and if people are doing that, maybe they will do the famous pregnant care. I don't know if there are other things. I guess that is what has been there for some time. But now the folic acid aspect that you're bringing in, you said it actually helps you to escape
congenital problems associated with the spine. So there's a group of congenital problems, problems that children are born with that affect the spine, whereby part of the spinal cord is protruding from the back.
And that happens to 2/3 of children.
No, not 2/3 of children. It happens, it's a rare condition, but in those that take folic acid, their risk is reduced by 2/3. So you don't get mothers who are on folic acid developing that condition. Their babies developing that condition. So, and that's just one aspect of it. When they come, there's so many other things that we want to do, because we have mothers who, like we said, they might have pre-existing conditions that they are unaware of. So when you come for preconception counseling, we'll have a conversation, and we might be able to pick out certain things. Even during routine screening, we might be able to pick out conditions such as hypertension in you. And we are aware there are a number of medical conditions which are exacerbated by pregnancy. They are worsened during pregnancy. So when we pick them early, we are able to start management, and the mother can enter pregnancy with these conditions already controlled. So what that means is that then we are aware during pregnancy, and we can take the required action. And also, they don't tend to be severe forms of those diseases. Examples are thyroid disease in pregnancy, diabetes, hypertensive disorders. All those, if we pick them and manage them antenatally properly, they don't tend to disturb the mother as much during pregnancy. And again, just the fact that the healthcare provider and the mother is aware, then they'll get the appropriate treatment.
Yes. How soon should that be before conception? Should I come 3 months, 6 months to 1 year?
So realistically, we vouch for 3 months before conception. So, a couple that is considering getting a child can plan and just visit their healthcare provider 3 months, because even these supplements are meant to be started at least 3 months. They have the greatest benefit when they're started at least 3 months before conception. Nutritional supplement, the normal diet and change of the normal diet would be beneficial if it started 3 months before. When we talk of lifestyle modifications, some of the advice we give you, if you're someone who smokes cigarettes, takes alcohol, those are things we'd want you to stop now as you're preparing now to conceive. Another thing that you get advised on during preconception counseling is there are a number of women who are on medication that they might not even be aware of that could be harmful to their unborn child. And ideally, in our setup, you realize that most women would be coming for antenatal clinics maybe from the 2nd month. That's around 8 or 7 weeks, thereabouts, and those are the ones who come in early. But what happens is the greatest area of teratogenicity, or what we'd call harm that could come to a newborn occurs within the first trimester up to around 13 weeks. So by the time you're coming, you've already exposed your child to almost 8 weeks. So there are medicines that women can be taking off the counter or sometimes on prescription that they might not be aware that would be harmful to their children. So during preconception counseling, you're able to discuss with your healthcare provider. You're able to tell him all the medications you're on. Examples are some medications for heart conditions, such as warfarin, those patients who have had heart conditions before. Some medications for convulsive disorders. They have an effect on the unborn child. They are teratogenic, that's what we call them. So when you come in for preconception counseling, we're able to advise you and we give you alternatives, or we could tell you the minute you discover you're pregnant, you come so that we change these medications. So you see, by that point, we have not exposed the baby to 8 months. So at least we've cautioned the mother. So we're able to change this from these teratogenic drugs to other less harmful drugs for the baby. Yeah.
I'm actually impressed as I listen, and at the same time, I feel so bad that that this news is not out there. When people try to conceive, they just try to conceive, and they don't take it seriously. No one thinks about such things in detail. And even though before they start their antenatal that we are moving into next, people wait until it is 3 months, as you said, 4 months, as you said. As long as no one is feeling something funny in their system, they don't want to go. And as long as you're also not struggling to conceive, you don't see the meaning of going for pre-conception counseling or seeing a doctor before then. So a lot of things people just take lightly and don't give much weight to, yet they're very important. Like the two aspects you have talked about in the preconception. I don't think that a lot of people, unless they're medics, know about that,
Yes, and it's also with the culture that we have, there's a joke that we say that most firstborns are come by mistake, so no one has planned for them. So subsequently, people can plan for the other children, but there's that component that makes it a bit harder for people. But if, we would push the knowledge out there, as you're saying, people would be more intentional about coming and seeking and, just getting over the counter. And even if you talk about this, supplements, I don't want to mention the name, you mentioned that's a particular brand, but there are many supplements out there. You will find that they have both prenatal supplements before pregnancy, conception, and then they have the antenatal supplements, and they even have those for lactating mothers because they contain different varying amounts of particular elements.
Okay.
So, so let's embrace prenatal counseling.
Just before we get to antenatal, still in the preconception care, you said it's important that we consider at least 3 months.
Yes.
So in the event that, as I am trying, the first month I conceive, what happens?
There's nothing wrong with that.
Oh, so you just carry on?
You just carry on because you're better than that person who didn't do anything at all. So like we said, the body is normally, for example, with the supplements, has its own way of storing these nutrients. So when we advocate for you to take folic acid, for example, for 3 months before, the body is storing up these nutrients.
So do you, by the way, take the 3 months supplements alongside your birth controls? Because, if you are intentional about taking these medicines for 3 months before you conceive, you're intentionally preparing your body for this period of time. Are you supposed to stay on your birth controls to ensure that you have consumed well the 3 months supplement?
I would not necessarily say you need to be on birth control. Remember, even the minute you finish this 3-month period, it's not automatic that you will now say, I'm done, now let me get pregnant now. Remember, it might take a while. So what we normally say, the minute as a couple you decide you want to get pregnant, just come in for the preconception. We'll start you on the medication. Because it's a process from the time you decide to get pregnant to the time
there
you
are
actually...
people who, they decide, and some don't decide. The oops baby, they are already on birth controls. But I don't know what happens.
Well, we normally don't advocate during this preconception period per se that you should be on a very strict birth control regimen. Okay. That's not really something we would push for, because even when you do stop, it doesn't mean that you conceive the next month.
All right. So antenatal, what is this? You said, if I heard you right, that it is the care given to women who have already conceived.
So This is just a broad term when we talk about antenatal care of, the care and attention that we give to women who are already pregnant from the time they discover they are pregnant to the time that they are now going into labor.
Not from 5 months.
Not from 5 months, not from 6 months. And we've done well as a country because we've moved. The figures are not so bad now. We are talking about almost above 80% of women attending at least one ANC visit in the whole country, which is an improvement. Attending at least one.
Oh, it's possible not to attend?
Yes, we have women who go through the whole process of childbirth and they don't attend. And I'm saying this 80% is an improvement because in the past the figures have been quite low. So
what happens to women when they just get to hospital and they labor and they've never had any ANC?
You are assuming that they are getting to hospitals as well. So we have women previously who could, from the time of conception all through to the time when they conceive, when they deliver at home, they have not stepped up in a health facility. So this is an improvement, and we are getting more and more women coming up, so we are happy about that. So, yes, so this is from the time you discover you're pregnant and not, like you said, from 5 months. It should be from the time you discover you're pregnant. And I'll take you through why it is important to begin your process as early as possible.
Okay.
Again, during antenatal, there's a number of things that we'll want to do. There's, of course, the antenatal counseling that you'll receive from your doctor. And, this will include things like nutrition, But ideally, when you come in for your first visit, there's a series of tests that you alluded to even at the beginning that we normally carry out. And these tests are important. We call them the antenatal profile. Because they are specific things that we are looking for. And we are not just doing tests for the sake of doing. When we discover something is wrong, we are able to treat it early to prevent the repercussions to the baby. For instance, we screen for STIs. So we do screening for HIV and syphilis during pregnancy. So when we do screening for HIV, one of the things we do is, should a mother turn positive, we initiate her on antiretroviral therapy immediately. So what this means is we reduce the risk of mother-to-child transmission of HIV. So that has a specific benefit. Because remember, there is
the risk of transfer.
Of transmission.
I thought transmission can only happen at birth.
No. Transmission occurs in utero to a small degree, and also mainly during the process of childbirth. So what we do, depending now, the minute you come in and we do a test and you're discovered to be HIV positive, we begin you on antiretroviral therapy. Because what this does, it reduces your viral load and increases your CD4 levels. So once you reduce the viral load, it means the risk of transmission, even at that delivery, in the future, is reduced significantly, whether via cesarean or via normal delivery. Some of the other tests that we normally do are just the usual hemoglobin levels. We want to see how the mother is faring. If she has low HB, then we're able to make an intervention from that point. We begin her on medications to boost her HB. So you can see that all these measures have a specific, we're not just running this test for the sake of running them. Every result that you get has a consequent action that you will take depending on the outcome. So the first thing you do is that antenatal profile. So the other thing that we normally do is we normally do the first ultrasound, the first obstetric ultrasound. So if you're coming in at 8 weeks, or as early enough as you're coming in, the importance of this ultrasound will be one. It tells us that you're carrying a pregnancy that is even in your uterus. You've heard of ectopic pregnancies.
Yes, not in the tubes.
Yes, the baby is not in the uterus but is in the tubes. So these ones are normally discovered by mistake most of the time, because by that time most mothers have not, they were still at home. They were like, I'll wait till month 2 or 3. But if mothers would come to hospital immediately they discovered they were pregnant, then we'd reduce the chances of ectopic pregnancies getting us off guard, because we'd be able to identify them early enough through routine ultrasound screening. So as of now, I think, if I were to give a number, maybe 90% of all the ectopic pregnancies we deal with come as an emergency, because the mother was at home, she was in extreme pain, then she came to hospital, and then we picked it up.
Well,
So
I wanted to take a break and come back to that,
Okay.
because I think that is very, very important.
All right.
Especially the fact that you got to do an ultrasound in your first visit. I thought an ultrasound begins from 5 weeks. So viewer, we're taking a break. We are talking about maternal care, and I'm here with Dr. Moses taking us through the 4 stages in the maternal care that we all need to know. Coming back shortly. Welcome back. We are discussing maternal care. So we are at antenatal care.
Yeah.
And you have advised that as soon as the woman realizes she's pregnant, she needs to go to the hospital. One of the things you have mentioned that I find very key is that as early as 4 weeks pregnant, you are able to discover that there's an ectopic pregnancy. As in, there's, you know, I have tested and found that I'm positive. You know, I am pregnant. But you are able to check when you do the scan. The importance of having that ultrasound is that I could, yes, be positive, but in my uterus there's nothing.
Yes.
Meaning the baby has been conceived in the tubes.
Yes. So essentially, and not necessarily 4 weeks, I didn't mention 4 weeks, I just said as early as from the point that you discover that you're pregnant, just come in. At 4 weeks, even a normal gestation might not be very clear on ultrasound scan, but we'd be able to see what we refer to as a gestational sac. We might not be able to see clearly and say, oh, what's happening inside. But when you come in at, let's say, 6 or 7 weeks gestation, and we are doing an ultrasound and we cannot see anything in your uterus, then we ask ourselves, why is your pregnancy test positive? So that means that we have to start looking elsewhere for presence of that. And that's important because we're able to pick up ectopic pregnancies early enough. Some of the other benefits of coming in for antenatal early is, like I mentioned, a lot of women do have coexisting illnesses that they are not aware of. So we're able to screen for that. During your first visit, we do a random blood sugar. That is a test, screening test, just a basic screening test for diabetes. So if you had features of diabetes that were, you know, you had not, no one had, you didn't know about, we'd be able to pick it during your first visit, as much as there are more advanced laboratory tests that we do later on to confirm that. And the essence of picking anything early is you're able to start treating it early. Women with, again, hypertensive diseases are able to be picked early. And we also have women who have a history of abortive outcome. This is a woman who has had multiple repeated, you know, miscarriages. So when you come in early for your antenatal visit, there's a lot that we can do to make sure that this pregnancy does not also have the same outcome that is a miscarriage. So there are medications that we start you on, you know, hormonal supplementation, to make sure that if, for example, the cause of your miscarriages was insufficient amount of a hormone we call progesterone, that we give you that hormone as a supplement, so that at least we can carry your pregnancy, you know, further than the years to term. Some women, they have been having their miscarriages maybe much later, and one of the most common causes of that is something we refer to as cervical insufficiency. So if you come early, we're able to plan for you. We're able to do ultrasounds and see the state of your cervix, and plan for you at the end of, just at the end of the first trimester, to do what we call cervical sacrilege. We put a stitch around the cervix to prevent it from opening up before the time it's supposed to open up.
That is done that early or a little
Yes,
bit
it's
later?
it's done at exactly 12 weeks or around 12 weeks, the stitch. But you see, if you've, you know, if you're presenting to us at the first time 3-4 months down the line, you will miss that window, because there's, again, if you come too late, we can't put the stitch. So then you'll not benefit.
So after 12 weeks, this cannot be done?
It cannot be done because the risk of perforating the membranes is very high. So you'll cause more problems than good.
Rupture.
Yes, rupture of membranes, and that comes with the, you know, that one now we have to terminate the pregnancy. So you have to come in early so that we plan for you, so that we tell you now, you go, come back next month at 12 weeks, come on this date, we are coming to put a stitch so that you don't lose this pregnancy as well. So the benefits are so many of starting your ANC early.
So people who have had multiple miscarriages, is it that they did not have previous DNC, they did not have cleanings before, or what happened that this recurs?
Again, depends on the causes of miscarriages. Unfortunately, most of the time we're not able to ascertain or state with with a lot of clarity that this is the cause of your miscarriages. However, because we know that certain miscarriages caused by certain causes occur at specific times. So if you're coming to us with, second trimester, late second trimester miscarriages, and we see the pattern, the first time you lost it at 28 weeks, next you came to 26 weeks, 24, then we now assess your cervix. The most likely cause is an incompetent cervix. So we just come and put the stitch, like I said, early enough. If the causes are occurring much earlier, at month 1 or month 2, then that points out to what we call genetic or chromosomal abnormalities. And those ones, some of them, there's not much we can do. We are still at a place in the country we're not able to do something we call genetic karyotyping. We're not able to look at these chromosomes and say your partner and you, when you come together, you're not able to get a viable fetus. But other causes that occur during that first trimester, is what I was talking about. Hormone insufficiency. So a lot of women who come at that early stage and we put them on supplementation with progesterone, they're able to carry their pregnancies past that stage that they would get.
So that will still get you back to the benefit of the preconception care.
Yes, because some of these are things you actually started discussing during preconception, and your doctor told you the minute you get pregnant, just come in, I'll start your next and next medication, so that at least this time round we don't go through the same channels. Yeah.
I imagine that for women who have to go through the antenatal, beginning from that early, they somehow get tired, and a lot of them also that do not have problems at all, they don't see the need. They don't see the need of going. There are people who just go to the clinic, for ANC just thrice.
Okay, that's true.
How often should this be?
In the past, the WHO had given us a model for use in our, Kenya and other, less developed countries, and they talked about the four ANC visits. They required a woman to attend at least 4 ANC visits, which were well structured. But because it was seen that a lot was being missed out, we came up with something called a focused ANC schedule that actually reduced it and increased the number of visits. In practice, however, it's very different, and every case carries its own merit. Not going to subject all women to the same, visits. Routinely, most of the women we see, we give them return dates of 1 month if they don't have any issue, routinely. There are women who we do require to see more frequently than that. I mean, if you are having diabetes and you don't have good control, and this is, it's fast peaks during pregnancy, we know we need to get you to a place where we've stabilized. We know this amount of medication is what is able to control you, so we'll give you maybe 2 weekly, before everything stabilizes. So every woman would be different, but ideally, a visit to your healthcare provider once a month is something that should be, you can't overrate it and say, oh, I don't have a problem, just once a month. And sometimes you come and there's nothing we're doing. You might think there's nothing we're doing. But remember, during every visit, we are taking your blood pressure, so we are monitoring you for that. We are auscultating, we are listening to your baby. So we are listening to the fact that...
We don't just imagine that you're paying 3,000 consultation to see a gyna and they only took blood pressure.
They only took... That is just one part. You'll come, they'll take your blood pressure, your weight.
You're actually monitoring a lot.
There's a lot that is happening.
So we should not assume...
Yes.
That we are coming to pay 3K to just have blood pressure.
I mean, even where it is free.
The doctor didn't even check.
Even where it's free and where it's 100 shillings, women still struggle coming, the requisite number of times.
Because we are accustomed to feeling something before we see a doctor.
Yes. And that's the notion that
so
we want to
I'm not
move away
spotting,
from.
I'm not in pain, I'm not cramping. I'm like, my baby's okay.
My baby's moving normally, so I don't have to come. No, that's the notion that we want to discourage and we want to move away from. Because we pick a lot during normal antenatal visits. A woman would just come in, walk in, she's okay, she's like, mi sinanga kitu bana, nasikia nimechoka choka nini. You take her sugars, you find her sugars are off the chart. You take her pressures are off the chart. So those are things that she would not have picked. And some don't even go back home. We tell them we can't give you permission to go back home. This is something that actually requires admission. So it's not once a month is is what we are moving by. And based on the number, where most women come for clinic, this still amounts to 6 or maximum 7 visits per pregnancy. Closer towards childbirth, again, the return dates become shorter because there's much more that we need to check. At 36 weeks, I'll not tell you come back in 1 month. I'll probably tell you come back in 2 weeks. Yeah, because then you'll have more issues, even you yourself, that you need to share with me as your doctor. Yeah, so
I need us to take another break because this is really interesting. I like the way people say it's never that serious, yet it is actually
Very
so
serious,
serious. Yeah, so viewer, I hope you are taking notes of this and the importance of having this ANC. Don't just do once and wait for the birth of the baby. At least do 7 as the doctor is advising. We are coming back just now. Welcome back. We have a lot to discuss, actually, Dr. Moses, and we have so far just touched on 2, which we have not even exhausted. But I'd like us to move to intrapartum care and then get to the postpartum. And then if we have time, we will bounce back to the ANC. So what did you say is intrapartum? If I got you right, you must have mentioned it is the care given during delivery?
During delivery, yes.
Okay.
This is the attention and care we give to pregnant women when they come in labor, from the time their labor starts till the time they deliver their babies. And again, it's, if you follow what you're saying, it's interesting because, in the animal kingdom, animals just go and they deliver without anyone. And we also have women who just come to hospital and they delivered without it. But if you think about all that we do during the hospital setup, I say a lot of women are very lucky because there's a lot that goes into this monitoring during the time that you present in labor. Yes. So the key aspect of intrapartum monitoring is making sure that we achieve delivery of a healthy newborn, and we achieve it within the safety compass of that both the mother and the baby will be okay. So that's the key. That's the key objective of.
What is that exactly? Because, like you have said, there are women who are like, the strong animals. They will just push and they're okay. And if you talk about safety of the mother and the baby, my mind goes to, the woman who is HIV positive and is avoiding transmission to the baby. They probably, because I don't know what happens with the cords, that if this touches this or connects with this, then transmission is done. But you also mentioned that this transmission is curbed in the first trimester, where you begin with taking the ARVs.
All right, I'll talk about that, but that's a small component of all the mothers that you're delivering.
Okay.
So when I say intrapartum, the intrapartum care that we give with the aim of achieving a healthy baby is because when you present to the hospital the first time, the first thing that we do, other than the general well-being assessment of the mother, is we begin our fetal heart rate monitoring of the baby.
Okay.
There is a manner in which we monitor the baby's heart rate because that tells us how the baby is faring. So there are parameters that we'll use to tell us how the baby is faring. We'll look at the heart rate, we'll look at the amniotic fluid that is draining. So this heart rate, if it starts to meander in the either direction, if it becomes too fast, more than the normal, or if it is too slow, more than what it should be, then our alarms are raised and we start thinking, why is there a problem with the baby? And we need to intervene. So the other thing that we monitor is the amniotic fluid that the mother is draining. So during each assessment, we check for that. Because when you find that, there is what we call meconium staining in amniotic fluid, In layman, when you go to hospital, you'll be told mtoto alichoka. That's why the doctors had to send her for section. Those are the things we monitor. And at facilities like ours, we are able to do both the manual monitoring, which means just listening to, with the heartbeat, with the manual, we call it a pinhead stethoscope or a fetoscope. But we're also able to do electronic fetal monitoring.
Okay.
So this is use of devices that are able, we place on the mother's abdomen that are able to tell us how is the heart rate of the baby. Not just how is it, but how is it, this, what we call variability. There's a bunch of things
graph.
that we look up. Yes, exactly. There's a graph and patterns that it creates for us that we are now able to assess and say, from experience, when this behaves like this baby is not doing very well and we need to remove this baby ASAP, because failure to do that will result in a bad outcome. So that's one aspect of, intrapartum monitoring, the fetal heart rate assessment, or the fetal parameters assessment.
How does that manifest so that instead of me just assuming, you know what, I've done this 3 times in the past, I can do this 4th one again. You know, I just assume that I am strong to do this. What should lead me to run to you?
The minute you get labor, which presents as remember from roughly close to term around 37, 38 weeks, women develop a bit of low abdominal pains that we sometimes call, could be due to pressure. We call them the pressure symptoms. Sometimes there is contractions which are not labor-like, but they actually present. We call them the Braxton Hicks contractions. They come and they mimic, labor, but it's not true labor. You also call it false labor, But when true labor comes, we tell mothers, the minute you find that you're having, pain in your lower abdomen, these contractions are coming in a sequence. They're increasing in their intensity. You are feeling it but then over the past 1 hour, it has become more intense. And the duration between each contraction is reducing, then you know that you are now in labor. So you present yourself to hospital. So from that point is when we take over and we begin all this monitoring.
But now there's this woman who has done 3 babies.
At home or in the hospital?
Home.
Yes.
And they know they are strong to handle this.
Yeah.
But when the baby's heartbeat, the variables are presenting, the mother is not able to tell that the heartbeat of the baby is low or too fast.
Yes. So,
is there anything that I can feel to let me know, much as I have been that hero, today I must run?
You see, first I want to discourage. Yes, even those mothers who have delivered 4 times at home, we are saying let them go to a health facility. You've been lucky 4 times. You don't know whether the 5th time you're going to be just as lucky. And a lot of children also are born at home with a lot of conditions that you don't get to know. Yes, you had a successful delivery, but the implications of these deliveries come much later. Even in hospitals, much later. You've heard of the cerebral palsies. All these jaundice may not be even a problem because that's treatable. All these children who go through a very difficult delivery and develop what we call birth asphyxia. Those who get even severe birth asphyxia, they're convulsing after delivery and all those. So you as the traditional birth attendant or the woman at home, you are very happy that you delivered, you didn't go to hospital. But now what you have is a baby who is to some level of degree incapacitated. They do not have the normal developmental milestones. And with varying levels, that's how we get the children with cerebral palsy with varying levels.
When does that present?
Well, nowadays research is showing that it also presents in utero, but we've had instances. A difficult delivery associated with a very low score has its implications on the baby. That's why just delivering a child is not our aim. And that's why when I said the purpose of intrapartum monitoring care to a woman is to ensure a safe delivery for both mother and child. It's not just to ensure delivery. It's not just to ensure delivery. Because if that were the case, we'd allow women to labor for 2-3 days and we'd be okay with it. But we've seen that when the women undergo such stressful and such long birth processes, the outcomes is that these children develop complications much later. They have a delay in their developmental milestones. They take longer to walk. They take longer to speak. They have cognition challenges. So why go through all that if you came to hospital and we monitored, and we were able to make interventions. And interventions does not necessarily mean me taking you for for a cesarean section. There are so many other things that we can do that we can try and expedite the process so that the birth process does not take too long. But ultimately, where we see that there's a problem and we're able to pick it up early, we always intervene by means of taking for a cesarean section.
Wow, that is very, very important. I'm afraid we are not having a lot of time, and so I would like you to just touch on, the postpartum care. I know that this is after you have delivered, and a lot of times, once I have pushed the baby, the doctor check, the pediatrician comes and says, "Mtoto ako sawa," then we go. Then later, I don't know where you have to check, did the baby cry, and even how they cried, that is still an issue. You people learn so many things in school. Please tell us.
So I'll try and summarize it because I know maybe time is not allowed, but postpartum is extensive as well. And, essentially comprises, again, the care and attention you want to give a mother and her child from the time the baby is born till at least up to 6 weeks of delivery, post-delivery. And when you look at it for the mother, there's a lot that is involved again. Again, there's the element of, health counseling. Some mothers this is their first time, they don't know what to do with the baby. So they need counseling on everything, from breastfeeding, how do you position the baby, how
do you breastfeed sitting or lying down?
How do you hold the baby, how do you clean your baby,
how do you sit, taking care of your back.
Remember, this is a woman who has just come from the birth process, so whether cesarean section or vaginal delivery. So we need to discuss with her hygiene and how to take care of herself now post-delivery. If it's post-cesarean section, we'll take her through how to take care of her wound when she goes home. What are the danger signs for both her and the baby? If it's a vaginal delivery, maybe she had a tear. We'll teach her how to clean it, how to take care of it. If it was an episiotomy, which is a intentional tear given to increase room so the baby can come out. If that was there, then we'll also take her through the process of, how do you clean it, how do you care for it. And there are so many other aspects that we discuss, basically. There are things like, return to sexual intimacy. Those are things that will be covered. Maybe not
after
at the immediate ANC, but during the first review, those are things that will be covered. Remember, like I said, postnatal, not the first postnatal. Postnatal covers a wide range. There's the immediate postnatal challenges. There are postnatal challenges as you move along. So the immediate postnatal challenges for the mother would be, things to do with bleeding. We talk to her about, how much bleeding is too much, like
what is normal.
Yes, what is normal, like go home, watch out for this. We'll talk to her about sepsis. If you go and you find that, the blood, we call it lochia, that is coming out is, of this and this nature, then you might have an infection, so please come back. If you have pain in your abdomen, come back, you could have an infection. We'll teach her the danger signs for the baby, when the baby is infected, how to check how to clean the cord, and if the cord is infected. So that would be for the immediate postpartum period.
I need to ask you just 2 questions before we get to a close of this. One is, when does she resume intimacy? And 2 is, what is the importance of knowing your blood group?
Okay.
Yes.
So again, when does a woman resume intimacy is a question that is again very specific for each woman. We normally advocate for at least 4 weeks post-delivery.
Okay.
And the reason for this is, one, the woman has had a significant trauma to her body, whether her delivery was via cesarean section or by normal delivery. If via cesarean section, she still has a wound that she's trying to heal. If via normal delivery, the process of childbirth is associated with many minor tears and cuts in the vagina that, may not be visible outside, but she would still heal. So anything less than that 4 weeks might result in a bit of discomfort for the mother.
But not dangerous.
It's not dangerous. That's what I was about to say. Again, it's not capped in stone that, do not have intercourse 4 weeks after delivery. No. There are people who are able to resume some sort of sexual intimacy that might not involve vaginal sex before that 4 weeks.
Yes.
Yes, so we don't really cap it, but that's normally our advice.
Okay.
Again, you want, if she had a tear or an episiotomy, you want it to heal first.
Yeah, yeah.
So those are the things that you advise her. When the fact what we tell them is,
Courtesy of the man's support.
yes,
Yes.
we tell her when you're ready to resume, that is when you should resume. When you as
She
a woman,
could be
you're
ready after 6 months.
of course, when she comes for subsequent visits, we will talk to her about it. Remember, postnatal visits, immediately the time that the mother has delivered, we are with her in hospital. So there's what we talk to her during the ward rounds, and we're done with her. But we aim to see her on scheduled visits. So the first postnatal visit is normally about 1 to 2 weeks after delivery. So there's what we discuss at that point. At that point, we are still concerned about any pre-existing conditions the mother had, or she hypertensive. We are still treating those diseases. We are still asking her about her blood loss. Is it bad? Is it what?
Okay.
By the time she's coming for second postnatal visit, which should be about 4 to 6 weeks, then we can initiate that conversation. And if she's telling us she's still not ready, she wants to wait for another 2 months, then we'll ask her why, and we'd want to know. Yeah.
Blood group?
Your question was on why is it important to carry out blood group. So
I could be rhesus negative, my partner is positive.
Yes.
Could be O and A.
So what happens is when a woman is rhesus negative, and these are the women we say, oh, you are O negative, AB negative, like that. When a woman is rhesus negative and the father of her child is positive, then most likely they get a positive child. Not most likely, they will definitely get a child
Because
who's
of
positive.
because the father is rhesus positive.
Yes, and
Okay.
the rhesus gene is dominant. So what happens is the mother can become sensitized. The problem is not normally with the first pregnancy.
Second.
The problem becomes with the second pregnancy. Because if these rhesus antigens cross into the mother develops antibodies towards these rhesus antigens, meaning the mother is treating these rhesus antigens, which she does not have, as being foreign to her. So her body is creating antibodies the same way it would create antibodies for any disease process.
And what would
any
that
foreign.
do to the child?
So for the current baby, it will not do anything. So in future pregnancies, the second pregnancies, if we did not give the mother this, what you refer to as anti-D in the first pregnancy, in the second pregnancy, then what happens, the mother's body begins to fight its own child, because now it's perceiving this child as a foreign body. So that's what happens.
Oh,
Yes.
so sad. Oh, this is very interesting and very informative. I'm afraid that we are actually out of time. But I must ask this question that somebody asked us from our previous talk. Last time we were talking about fitness and healthcare. And somebody asked that they are so slim and they would like to gain weight. They have such a flat tummy. As much as they eat, they are not gaining weight, they are not becoming fat. When we talked to the guest who was here last time, actually her opinion was that for this particular case, she needs to prescribe a particular diet, probably of more calories and more carbs than the vegetables, because this person could be having a lot of intake of fibers and vegetables that are not helping her to build up her muscle and even to gain weight. So Dr. Moses, I would like that at this time you would give us your parting shot. Your show has been a great one, and I believe that women have learned a lot. Yes.
So my parting shot, again, like I told you, myself, I'm an obstetrician gynecologist. I'm based at a specialist hospital, in Roy Family Hospital, the specialist branch. And all of these things that we've discussed here, those are things that we actually do on a daily basis. We like to make our women's experience a pleasurable journey. We say pregnancy must not be torturous for you. You must enjoy the journey. And our team of gynecologists and midwives are there ready to walk the journey with all the women who come to our facility. And all the services I've talked about, the intrapartum monitoring, the electronic monitoring, we have it there. And so please, those mothers who want to walk the journey to get pregnant, come for your preconception care. Those who are already pregnant, they can join us. We have very affordable packages for both insurance payers and cash-paying patients, and we'll be able to walk the journey. And I advise all women everywhere to embrace visiting your healthcare providers for preconception counseling, and as soon as they discover that they're pregnant, to plan and start their ANCs early, and to be religious to their ANCs. They don't just go for your ANCs when you have a challenge or when there's an issue. Yes.
To do so religiously.
To do so religiously.
Okay.
Think about that lovely bundle of joy you want to receive at the end, and this is the person who can help you get there, without any handicap. So it would be important for you to be religious to that cause.
Wow.
Yeah.
Thank you so much. That has been really informative. I am grateful that I was a receiver of all that information. One of the things that I'm also glad to have learned, and I hope, viewer, you got that, was the importance of pre-conception moment. That is very important. I don't know if Dr. Moses had told us whether at that point he can also help you to decide whether you want a girl or boy. But he said 3 months is very important to start that journey before, like about 3 months too. So please take care and go for your ANC religiously. Not just one, but about 6 or 7. My name is Betty. I have been excited to host you. See you next time.